Hi everyone, my name is Bonnie and today we're going to be talking about hemodynamics. So this is a pretty brief introduction to the concept of hemodynamics, but for more advanced information on the topic, keep an eye out for additional videos that are going to be coming your way. So starting off with hemodynamics, what is hemodynamics and what does it mean to be hemodynamically unstable? So for me, learning about what can be hemodynamically unstable was an important part of me understanding. And I would hear as I took care of patients in the hospital that, this person's really hemodynamically unstable, this person's hemodynamically stable, but maybe other things are going on. And so what exactly is hemodynamics? And to elaborate on this just a little bit and kind of give you an idea of the patient populations that this can encompass, I'm going to switch over real quick to the whiteboard function, and we're going to talk a little bit about what all this entails. Okay, so we're going to start off really basic with just the term hemodynamics. And what does that term mean? So this is really just very simply the movement of blood throughout the body. Movement of blood throughout the body. So when we think about what the blood carries and delivers to the tissues and the organs in the body, this is a really important concept to understand. Now, when I think about hemodynamics, the first question that I like to ask myself is, what kind of things can alter my hemodynamics? And if you're brand new to this concept of hemodynamics, I encourage you to think about what kind of things can alter and disrupt your cardiac output. Okay, so we're going to take a quick look at what is cardiac output and why is that important. So there is a very long list of things that that can influence hemodynamics, and we're going to fill up some of this board here in just a minute. But let's look real quick. What is cardiac output? So cardiac output, just from the definition itself, this is the amount of blood that is ejected by the heart in 1 minute. Okay, so this is the amount of blood, and really simply, this is the blood leaving the left ventricle of the heart. So the amount of blood pumped out of the left ventricle every single minute. This is measured in liters per minute. And if you're looking for a mathematical equation for cardiac output, this is very simply our heart rate times our stroke volume. And when we look at stroke volume, this is going to make a little bit more sense. So normal cardiac output is somewhere between 4 to 8 liters. Now, that is a pretty big gap, 4 to 8 liters. So cardiac output definitely has some limitations as a way to measure hemodynamic stability and instabilities. But I like the term cardiac output, and like I said, this is one of the first things that I ask myself when I think, this appears to be someone who's hemodynamically unstable, or I am concerned about being hemodynamically unstable. And so I really want to be thinking about what is their cardiac output. And this is a question that I ask myself for almost any patient in the ICU who's having fluctuations in their heart rate or in their blood pressure, temperatures, any change in vital signs. So let's go back and start to kind of create this long list that we have on things that change and influence cardiac output. So usually when I talk about changes in cardiac output, I will tell people I want you to throw out maybe a disease state. That could be it. It could be something else going on. Another thing that we measure that would indicate perhaps their cardiac output has changed, things like that. So anything that's changing the amount of blood coming out of the left ventricle. So this could be things like, sepsis, right? This could be things like dehydration. This could be things like states of shock. Now that could be, perhaps septic shock, a cardiogenic shock, lots of different forms of shock that can come up. Things that can change cardiac output could be somebody who is bleeding actively. This could be somebody who, is perhaps volume overloaded. They have too much volume on board. Of course, other things, this could be a heart rate that is perhaps either too high or too low. This could be perhaps their oxygenation is too low, changes in core body temperature can have an effect on cardiac output. They may have some type of renal disease. And really what I want you to get the idea of is that this list of things that influence and change your cardiac output, we could fill up this entire page of things that change cardiac output. And I'm not going to take the time to fill up the entire page just to prove a point, but I just want you to understand that there are a lot of things that can change cardiac output. And typically, the way that I like to sort of categorize these things is into a couple different categories. So the first one of these categories, the first one of these categories, this is going to be, I have a volume problem. Okay. The patient, and this is going to be for low cardiac output. The patient has either too much or too little volume. The second one of these problems is going to be, I have a pump problem. Okay. So what do I mean by a pump problem? I mean that they have a cardiac function issue. Their heart is not pumping as effectively, and so we're going to call that a decrease in perhaps our contractility. And oftentimes for us, this presents like somebody who has some form, not necessarily congested, but some form of heart failure. And we're going to call it CHF just to make it a little bit easier to start off with. So I've got a volume problem. I've got a pump problem. And the very last thing is going to be my vasculature. I've got a vascular problem. And so what do I mean by vascular problem? I mean that this person is either vasodilated, okay, or they are too vasoconstricted. And we'll look at why those things influence and make an effect on cardiac output here in a little bit. So between volume, CHF, and some type of vasodilation or vasoconstriction issue, I like to then further sort of throw these into some categories that may sound a little bit more familiar to you, but are kind of definitions that can be confusing if you haven't used them very often. So when we talk about volume, the first thing I'm going to do here, this is going to be our preload. Okay, so I've got a preload. I'm going to relate that to volume. For number 2, this is going to be sort of my contractility, which we talked a little bit about. Contractility, let me spell that right. And then the third one, this is going to be my afterload. Okay. So this makes sense if I kind of remind myself of what do these definitions mean. So preload very simply means the amount of volume returning or blood returning to the right side of the heart. So what I'm measuring when I look at preload is how much blood is being circulated and delivered back to the right side of the heart. When I look at contractility, this is really looking at the heart itself. and looking at how well the heart itself can function. And then thirdly, a look at afterload. So preload being before the heart, contractility being at the heart level, and afterload being after the heart. So afterload is really how hard the left ventricle has to work to pump blood out. So kind of how much pressure does the left ventricle have to work against in order to eject blood? Okay, so these three concepts, 1, 2, and 3, pretty much everything on our list of things that influence cardiac output over here can be sort of tossed into at least one of these three categories, whether it's preload, contractility, or afterload. And oftentimes they can be thrown into more than one of these categories. So we're going to take a brief look back at the PowerPoint and just go through some other different types of hemodynamic parameters. So these are going to be, when we talk about hemodynamic parameters, it's really important. These are all ways that we can measure parts of our hemodynamics or parts of our hemodynamics. So all of these parameters that help us evaluate a patient and say, wow, that person's either hemodynamically stable or hemodynamically unstable, and this is why. And there are a lot of hemodynamic parameters. We're going to look at some of the primary ones and just briefly define them and kind of look at their function here. So starting off, of course, cardiac output is one of the primary ones. It's a very helpful hemodynamic parameter, but you'll notice that I kind of have this normal value that's very large, which I mentioned earlier. So somewhere between 4 liters and 8 liters per minute of blood leaving the left ventricle. And this is actually one of the reasons why cardiac output, though it is the first question I ask myself about, it is actually not the value that I prefer to use. I typically will prefer to use this value here, and this is cardiac index. So what cardiac index is cardiac output divided by the body surface area. So what that means is that cardiac index takes into account the size of the patient. And so why is that helpful? Well, if I have, let's say, a patient who is, 6 feet tall and weighs 70 kilograms, okay? And then I have another patient who's 5 feet tall and 70 kilograms. And both of these patients have a, well, actually, I'm going to make this person much lighter. I'm going to say 40 kilograms for the 5 foot tall person. We'll make them a little bit healthier. So, and both of these individuals have a cardiac output of 4.5 liters per minute. Okay, now 4.5, remember if normal is between 4 and 8, 4.5 is within the normal range of a cardiac output. So if I only looked at, this value standing alone, it would tell me, well, that cardiac output is actually normal. However, this individual who's 6 feet tall probably has a much higher blood volume than this individual who is 5 feet tall. So at 4.5 liters per minute, this person over here, this 5 foot tall person, this person is probably feeling pretty good. They're probably functioning relatively normally. However, this person over here, this 6 foot tall individual, this person is probably not feeling so good at a cardiac output of 4.5 liters because for them, their cardiac output may normally be, 6.5 liters per minute. That may, whoops, that may be more of what they're used to. Whereas 4.5 for this individual who's 5 feet tall may be, very well normal for them, and they feel completely fine. So that is one of the reasons, changes in the size of your adult populations, between someone who may be very small versus someone who's very large can make just that base value of cardiac output sort of confusing. And then also, if you're taking care of pediatric patients, utilizing an adult cardiac output, if that's what you're familiar with, occasionally, it's been many years since I worked with a true pediatric patient population, but occasionally I will see patients who are, um, 14 years old with the sort of development of maybe someone who is 11, who's quite petite. And so that's where using values like cardiac index comes into play. Because if we were to, and I'm going to label this, the 6 foot tall patient is going to be patient A, and the 5 foot tall patient is going to be patient B. If I were to then calculate their cardiac index, what that would tell me is that patient A, okay, and we're going to use this cardiac output of 4.5 right here. Patient A may only have a cardiac index of 1.9 liters per meter square per minute. So what that tells me is, looking at this normal range of 2.5 to 4, if I have a cardiac output of 1.9, that tells me that, hey, this person is not hemodynamically in the best state, and what can we do to kind of help them out and get them settled a little bit. But if I looked at patient B with a cardiac output of 4.5 liters per minute and this 5 foot patient who's functioning relatively normally, this may tell me that their cardiac index may be 3.1 liters per meter squared per minute. So that would indicate to me, that this person, once again, very happy heart, everything, it's getting what it needs, the body's getting what it needs, and this 1.9, well, that's no good. We'll give them eyeballs. How about that? We won't make them unconscious yet. So I like to use cardiac index. I think it's a much more accurate reflection of what's actually happening with the patient, and allows me to get a much more accurate picture for assessing someone's hemodynamic status. Okay, so let's move on and look at some other values, some things that can change based off of some other parameters. So a couple other parameters that we wrote down were, heart rate, changes in heart rate. And on that first page, I wrote, heart rate either being too high or too low. Both of these things can cause problems. This is a really good reference slide to kind of look at things that can cause bradycardia. In a normal patient, if someone is bradycardic, we would then expect their cardiac output, cardiac index to drop. And really that makes sense if we think about the baseline of this equation. Remember, cardiac output is heart rate times stroke volume. So if my heart rate falls, it would make sense that my cardiac output would also fall. Just kind of basic math principles. So these are just some examples of things that can cause bradyarrhythmias in patients. And one of the other things that I like to point out is the patients oftentimes, we may see a heart rate fall or a heart rate increase initially, and what we see is a very stable blood pressure. Okay, and over here in big bold capital letters, I did that on purpose. A lot of people say, well, yeah, I mean, their heart rate's 160, but their blood pressure looks fine, so they're not unstable yet. So one of the things that I think is important to note is that blood pressure is one of the last things to change when we talk about somebody losing hemodynamic stability. So what that means is that the body will continue to compensate to a low blood pressure. It will say, okay, I need to release some catecholamines to kind of help my vessels constrict. And what that means is that my blood pressure is actually going to sometimes go up. It's going to help continue to provide preload when my blood vessels constrict and continue to provide blood coming back to the right ventricle, but eventually the body loses that ability to compensate. And so let's just go back just for a second and look at what does this look like in a patient who has been compensating. Okay, so I'm going to clear up some of this. And let's say this is our patient here, and oftentimes, let's say this is their blood pressure. This is kind of what I see. Many times what happens is this person is compensating, and I may see small fluctuations in this line. And then what I hear often, especially from nursing staff, is the patient has been fine all day, and then all of a sudden their blood pressure was 70/30. But they've been fine all day. And so oftentimes what that looks like is this person is quote unquote fine all day, and then they really start to deteriorate. Okay. Now, why does that happen? So this is, let me label this one. This is my blood pressure here in black. This is my blood pressure. So this is kind of what I'm seeing. And the next line I'm going to demonstrate is going to be my cardiac output. Okay. So this is my cardiac output. All right. So what does that tell me? It tells me that, this patient, as this gap continues to widen between what's happening with my cardiac output and what's happening with my blood pressure, is I'm seeing the patient compensate. Okay, the patient is still able to compensate. And that tells me a little bit about where they are is compensating. That tells me a little bit about where they are in their disease process. So as somebody is compensating, this is releasing endogenous catecholamines. So those are our chemicals like norepinephrine, things like that help increase our blood pressure. So I've got my endogenous catecholamines. This is going to cause those peripheral vessels to really vasoconstrict to help maintain a good blood pressure. And then at some point, this ability to compensate will be lost, and that's really when we start to see this kind of fall here in the blood pressure. So this is sort of marks our loss of compensation here, where the body says, I'm trying to maintain cardiac output. I'm doing all these things that I know how to do to maintain cardiac output, but we're still not fixing this problem right here. We still haven't addressed why is my cardiac output continuing to fall. And this curve here, this is a pretty simple curve, and we can use a different example. So this would be an example of somebody who is continuing to deteriorate and perhaps is in some sort of state of shock. But next, let's look at somebody who's healthy, who needs these compensation factors. Okay, so we're going to say this is going to be me, and I am going to have just been really dehydrated. Okay, so over time, I'm really, really dehydrated. I am just super busy, tied up at work, and I just can't seem to rehydrate. I don't have time. Now, every time I get dehydrated, my blood pressure does not fall into the 70s, but what it does is it maintains, and it maintains by the exact same compensation mechanisms that we talked about up here, with vasoconstriction to help sort of maintain my blood pressure. Maybe my heart rate goes up a little bit. And it's trying really hard to kind of keep that cardiac output at a relatively normal basis. So I'm doing a good job. As my cardiac output starts to fall, I get these other forms of compensation. And then, I say, gosh, I don't feel that good. I think I really need to drink some water. So I'm going to add volume here. When I add volume, I fix the problem on dehydration, and now my cardiac output gets to swing back up. My blood pressure, once again, has kind of remained stable, and everybody's kind of copacetic. So what that tells me is if I address and fix the problem here, which in this scenario with me being dehydrated was a volume problem. So if we remember earlier, we talked about this being a preload problem. So I addressed this. It is now fixed, and my cardiac output is back up to normal. And that allows my compensation to sort of relax, my compensatory mechanisms to kind of relax a little bit, with that release of catecholamines and vasoconstriction. And I can get back to sort of a homeostatic state. Okay, so looking back at what is stroke volume, we're going to look at the next one. And actually, before I do that, I just want to point out that I did include these details about an atrial kick, and that's really more so for reference. I'm not going to spend too much time talking about the atrial kick, but what I do want to include is that the atrial kick is basically something that happens when we have a healthy and a present P wave to indicate that my atria is contracting and relaxing at the points that it should. And that is helpful because the atrial kick can add up to 30 cc's of blood into the ventricle when it is present. And so when we look at what is stroke volume, that becomes very, very helpful. Okay. All right, so this quick review on cardiac cycles, it is helpful to kind of know a little bit about what's happening during each of these cycles. It really helped me very much so understand hemodynamics on a little bit of a different level. So when we look at one cardiac cycle, we're going to look at two different parts. One is systole and one is diastole. And we're going to look at the effects that an increasing heart rate has on systole and diastole. So essentially, and these percentages and numbers are examples, but essentially, as the heart rate goes up, systole time is prolonged and diastole is reduced. So why is that important? Well, let's look at what happens during each of these, okay? In systole, systole is the ejection of blood from the ventricles, whether it's the right ventricle or the left ventricle. So remember, the right ventricle is going into the pulmonary system, the left ventricle is going into the systemic rest of the body. And this is a very brief, intense contraction followed by the ejection of blood out of those ventricles. So what I'm seeing when my heart rate goes up is the body is telling me pump, 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 pump all this blood out and get it circulating. But what I'm missing, this decrease in diastole, this is really where we start to lose things. The diastole is when the ventricles have time to fill from the atria. This is when the ventricles are actually being filled with blood. So if I don't allow them to be filled, what's being ejected is going to be of less volume. And the other part of this that is very, very helpful is the fact that during diastole, this is actually when our coronary arteries are perfused. So if I'm taking care of patients that have really severe coronary artery disease or some type of heart failure, cardiogenic shock, I have to recognize that I'm really stressing out the heart the faster the heart rate goes because those coronaries are not being perfused. So sometimes what's really interesting to me is sometimes, when we have these individuals, as the heart rate continues to increase, the filling times diastole continues to become shorter. Something that we may see in some of these individuals is signs of ischemia in their in some of the, especially in their rhythm changes. I may start to see ST changes, especially, once I get into that heart rate above 120. And of course, that risk factor just becomes greater and greater when we introduce the concept of cardiovascular disease and coronary artery disease. So really important to have a good diastolic time for the ventricles to fill. Okay, so I've talked a little bit about stroke volume, but what exactly is stroke volume and why is this important? We're going to follow it up. Stroke volume is the amount of blood ejected from the left ventricle each beat. Okay, so each beat, that is where it's a little bit different. Remember, cardiac output was the amount of blood ejected per minute out of the left ventricle. So whereas cardiac output is per minute, stroke volume is per beat, and that makes a lot of sense. If I think about, remember, what's that equation for cardiac output? I've got cardiac output is my heart rate times my stroke volume. So the amount of blood ejected per beat times how many beats per minute do I have will give me the amount of blood ejected per minute. So a normal for stroke volume, this value is pretty easy to remember. It is the same as heart rate, essentially. This is 60 cc's per beat. And once again, just like with most hemodynamic parameters, there's going to be an index value, and just like with cardiac output and cardiac index, I am definitely somebody who prefers to utilize the index value over the standard value, just to incorporate the patient's body surface area. So stroke volume index, we're looking somewhere between 35 and 60. And this gives us some information about myocardial contractility, but remember, other things that influence stroke volume would of course be how much volume is coming into the heart, and also how hard is it for the left ventricle to pump out. If I'm not getting anything in, I have very low preload, I'm not going to have very much coming out of the left ventricle. And the same, something similar but inverse goes for afterload. If my left ventricle is trying to pump out against a very, very high pressure system, if my afterload is very high, my vessels are very, very constricted, it is going to be a lot more difficult for the left ventricle to pump out blood, and therefore my stroke volume is going to be a little bit lower. So it can give us some information about contractility, but we have to take into consideration also what is the preload and what is the afterload. So let's talk a little bit about preload. All right, preload is essentially the way that we use it clinically. And you guys, when I talk a lot about hemodynamics, and especially when I talk about pharmacokinetics for things that influence hemodynamics, I'm really trying to narrow it down into what do we see clinically in these patients. There's a lot more detail in each of these topics that, we could spend the entire time talking about, one particular thing that I've breezed over quite quickly. But I'm really trying to narrow it down to what do you need to know clinically when you're taking care of these people. So we're going to look at preload first. This is essentially an indication of volume. So if you remember one thing, remember preload and volume. If my preload is very low, chances are I might have a volume problem. So this is really the volume of blood at the end of diastole. So remember, what's diastole? Diastole is the filling time, okay? So historically, we have had a little bit of a difficult time measuring this volume, and we still kind of have a little bit of a difficult time measuring this volume, especially depending on where you're working. You may or may not have access or training with certain pieces of equipment to kind of help determine this. But historically, what we have used to measure this is a lot of times a CVP. And a CVP is a central venous pressure. So how does this work? Let's swap over to the whiteboard just for a second. Okay, how does this work? I have in the right side of my heart, okay, here is my right atrium right here. This is not super accurate. This is going to be my pulmonary trunk. Well, so essentially what I have when I'm trying to measure a CVP is a we're going to call this the SVC and the IVC, superior and inferior vena cavas. Let's say I have an IJ central line. Okay, so this central line is going to come down and it's going to pop in about right here into the right atrium. So what we do when we measure a CVP is through a central line, so we need to have a CVL. And that CVL needs to be a central line that terminates somewhere near in the right atrium. If you have a femoral line, you're not going to be able to accurately measure a CVP. And central venous pressure tells me what is the pressure in the central venous system. And the right atrium is about as central as it can get. So what you'll notice is that when we talked about stroke volume and we talked about preload, and the definition of preload once again is with volume. Okay, so preload is volume. A central venous pressure is a pressure. So volume and pressure don't exactly equal each other and translate to each other very, very easily. So this is one of the limitations with a central venous pressure is that, a CVP of 5 does not tell me that, this person needs, let's say, a liter of IV fluid. Okay, that doesn't necessarily correlate. It doesn't tell me exactly how much volume they need, or if this person maybe needs something else. And so I am in no way saying that CVP is not a good way to measure preload, especially if you don't have anything else. CVP is can be a very useful tool, especially if it's a trendable number. And the concern that I more have is not with very low numbers, but is more so with very high numbers. So we're going to take a CVP of, let's say, 18. Okay, so I've got a CVP of 18. Now, perhaps that tells me that somebody needs to be maybe diuresed. And that is most likely. I think I spelled that wrong. And let's say their CVP drops to 12. So maybe they need more diuresis. Maybe they need some more Lasix or Bumex or whatever it is that they're receiving. But maybe 12 is about as low as it's going to get. Depending on different types of heart disease and heart dysfunction, your CVP can read, kind of inaccurately. So if I'm doing a spot check on somebody and all of a sudden I do a spot check and I've got a CVP of 12, well, that really doesn't give me any information. But if I hook up a CVP and they have a CVP of 18, I give them some Lasix, and now their central venous pressure is 12, that gives me a little bit of more information. So if I'm going to use a CVP on somebody as a way to help me troubleshoot or figure out what's going on from a preload standpoint, I'm definitely going to be trending that number. Okay, so other ways that we can measure this, and I'm not going to go into all of these details. This is sort of the history. How have we done this? Which is with Swan-Ganz catheters. We can have a direct RA or LA lines. I really don't see those very often anymore. Of course, the central venous pressure any type of right atrial pressure measurement, an RV EDVI is a right ventricular end diastolic, and then of course some wedge pressures to kind of give me an idea on volume. So that is really going to be for those departments that are a little bit more familiar and use Swan-Ganz pulmonary artery catheters a little bit more frequently in order to get some of these values, with the exception of a central venous pressure, which can be obtained just through a standard central line. So how do we do this now? We can, of course, use CVP as well, but we also have some other things that we can utilize. I'm not a huge fan of stroke volume variation down here at the bottom, so I don't use that one as much, but I do, especially depending on where I am, what my resources are. I'm often a big fan of ways that we can do non-invasive cardiac output monitoring. There is, and that's just what an ICOM stands for. There are other ways that we can measure our hemodynamic parameters through arterial lines and things like that. I historically am not a huge proponent of utilizing peripheral arterial lines to measure what's going on in central vessels, simply because of the compensation that we've talked about, where that peripheral vasculature is going to constrict and dilate based off of the body's needs if that patient is still able to compensate. So in that case, oftentimes what I may be reading is going to be, something that's inaccurate, and trying to read, say, in a left radial artery, what's happening in my left ventricle, and especially the patients who are on very, very high vasopressors. I have a difficult time sort of trusting those measurements as being accurate in any sort of capacity. So I'm a much bigger fan of looking at where can I get a really good picture of what's happening coming out of the left ventricle, and some of the non-invasive monitoring systems, do a little bit better job looking at that aorta versus a peripheral artery. All right, and over here I just included some normal values for some things that we measure. The central venous pressure, very common to measure. The PaOP, or very common to measure. And then the right ventricular and diastolic, kind of common to measure. And the Frank-Starling curve we're going to look at here in just a minute. So this is going to be our changes in stroke volume and in diastolic volume, which is, as a reminder, our preload. So how much volume is kind of sitting in the right ventricle, returning to the right side of the heart at the end of filling. And I like the Frank-Starling curve. I think it's a really good depiction of what's going on. Something that I think is a common misconception is a lot of people think that the curve will continue to do this and sort of fall off, but that actually does not happen. What happens is it sort of lowers and then just kind of, levels out, and actually the whole entire curve gets lower. So the whole curve actually shifts down at a certain point. And that's really what I mean when we're looking at these three phases of volume. Either volume is helpful, it does nothing, or it makes things worse. So that's where I say this curve simply doesn't just fall off and continue to decline. The entire curve shifts down and really drops stroke volume throughout the entire process of the heart contracting. And something interesting for those of you who take care of heart failure patients, and most, in the Southeast, almost everybody has some type of cardiac disease, and a lot of patients that come in to the intensive care units have some form of heart failure. And so this is really what we see when we look at someone who's got CHF. which is why getting some of the volume off and diuresing these patients can be very, very helpful. All right, so preload management, how do we fix this? Of course, diuretics are very helpful, getting some volume off. This is our, volume limited patients who we say, only drink this much every 24 hours. And then, of course, some vasodilators. So vasodilators essentially keep from continuing to just pump blood into or continuing to fill blood into the heart as it gets pretty full, as it struggles to manage the volume that it already has. And then, of course, examples of increasing preload. This is going to be our increase in volume and our increase in vasoconstriction. And we'll look at some examples of patients with severe preload dysfunction at the end. We'll do some case studies on someone. I'll probably do somebody who's in distributive shock. I think, sepsis has been a huge topic over the last several years. And, septic patient can end up in almost any environment these days. All right, moving on from preload, we're going to take a quick look at afterload. So afterload, I will go ahead and tell you guys, afterload is my favorite parameter to look at because I think it is the stepchild of hemodynamic parameters. It is the stepchild of hemodynamic monitoring. People think, oh, cardiac output, cardiac index. Yes, like what's coming out of the heart. Afterload is I think just fascinating. We can continue to give the heart all the resources that it wants, but if we make it really difficult or nearly impossible for the heart to eject blood out of the left ventricle, it doesn't matter how strong the heart is. It will get weak, it will get tired, and things will look worse. So afterload, if we remember, mentioned this a little bit earlier, this is the pressure the ventricle pumps against in order to eject blood, okay? So the higher the afterload, the harder the heart has to work. The harder the heart has to work, the more oxygen demands the heart has, the more energy demands the heart has, all right? So this kind of breaks up into two different forms. One is, of course, from the left ventricle, where we get systemic vascular resistance. Another name for systemic vascular resistance is total peripheral vascular resistance. They mean the exact same thing. The terms can be used interchangeably. And then, of course, the right ventricle is pulmonary vascular resistance. And the right ventricle is much smaller, much weaker than the left ventricle. So it is significantly more sensitive to increases in afterload than the left ventricle, which is why when we have pulmonary disease, oftentimes we see patients who end up developing right-sided heart failure. The right side of the heart cannot compensate and continue to work hard. So for the most part, what I'm going to talk about is going to be the left ventricle afterload, the systemic vascular resistance, and the total peripheral resistance. And the reason for that is because when we start to look at pulmonary vascular resistance and what's happening in the right ventricle, is that we sort of start to get into an entirely different topic. And so I want to mostly, it's a super fascinating topic, and I don't want to discount pulmonary vascular resistance. But the purposes of today and this talk is really more so looking at the systemic effects of it. Okay, so what happens in afterload? This is just a depiction of what happens in afterload to our stroke volume. Remember, what is stroke volume? The amount of blood being ejected, okay? So, of course, this makes sense. The amount of blood being ejected goes down as my afterload goes up. And the next one, looking at myocardial oxygen demand, is going to be my myocardial oxygen demand goes up when the workload of the heart goes up. So that makes sense. If I'm working hard on a treadmill, that sounds terrible, but if I'm working hard on a treadmill, my oxygen demand is going up. If my heart is working hard against a high afterload, its oxygen demand goes up. Okay, so let's take a little bit of a closer look as to why is afterload so important. So this really gives us some sort of idea. This is the equation for it. This is the normal parameters for it. Once again, we've got the standard SVR, TPR, and then we have the indexed values. So just like with cardiac output, cardiac index, stroke volume index, SVR and SVRI, TPR, TPRI, once again, interchangeable terms. I prefer to use the index value. And so somewhere around 1900 to 2400 dynes is going to be where that normal systemic vascular resistance sits. And I'm going to use the term SVRI to kind of refer to afterload and refer to workload on the heart. Even though I could very well be using the term TPRI, it's just SVRI is what I was trained on, so that language suits a little bit more towards what I tend to speak in. So let's look at causes of very, very low diuretics. And what I'm going to do is actually, we're going to toggle back over to the whiteboard real quick and do a little bit about afterload. So this may seem kind of silly. Okay, so this here is going to be a normal blood vessel, normal sized blood vessel. And the reason that I'm going to go into a little bit more detail on this is A, because afterload is something that I get really excited about, and B, this concept is very important to understand. Okay, so this is going to be a dilated, and then this is going to be a very constricted vessel. Okay, so which one of these, I'm going to label them A, B, and C, which one of these, dilated, normal, or constricted, is going to be the easiest for the left ventricle to pump against? Yeah, it's going to be the dilated one. So another way to think about this, and then when I teach live classes, I always like to use this example, is it's as a almost like a doorway. If the doorway is wide open, if the vessel is wide open, it is very easy to walk in and out of a room. The doorway is just swung completely open, propped open, and I can move in and out of that room really freely. If the door is functioning normally as it should, and I don't swing the door wide open every single time that I need to enter and exit a room, oftentimes I open it wide enough for me to walk through, and then I let it close behind me. So that would be kind of in our normal scenario. It's easier when the door is wide open, but it's not super taxing by any means to open up a door normally and walk through. However, if the door is got rusty hinges, or it's got a door stop on the other side, and the door's only going to open up a very, very small amount, let's say a couple of inches, 6 inches, it's going to be very difficult. I could probably squeeze through maybe, but it's going to be very difficult for me to get in and out of that room and go through that door. So that's kind of what happens when somebody is vasoconstricted. So this is a oftentimes very high increase in afterload. This is a very low afterload. And this would be somewhere normal. So remember, normal would be 1900 to 2400 roughly. So maybe in this very constricted model, we're going to say this is, someone who is has a SVRI of 3200, and somebody who's very dilated maybe has an SVRI of, let's say, 1200. All right, so very easy for the heart. And when I say for the heart, what I'm really referring to is it's very easy for the left ventricle, and this is hard for the left ventricle. This makes it a lot more hard, more difficult. So why is that? Why is that important to recognize and to treat? So what I'm going to do next is we're gonna take a patient scenario, okay? And I know we haven't gone all the way through this, but we're going to look at a patient scenario who comes in, and this person, we're going to say, is a 50-year-old female who presents with a positive urinary infection and comes in with a septic shock like picture. Okay, so she comes in and her blood pressure is 70/30. And what we know about her past medical history wise, she is one of our typical patients in Alabama, and she's got a history of diabetes. She's a little overweight. She has some coronary artery disease. Has had some stents. Has some heart failure, and doesn't exactly know that much about any of her disease processes because she hasn't been to the doctor in 10 years. Okay, so she comes in 70/30. What is our first course of treatment? Most likely going to be in the emergency department. In the emergency department, we're probably going to give some volume. Okay. Um, and as she continues to progress up to the ICU, we give some volume. Things look a little bit better, but not that great. Most likely, maybe we're going to give some more volume. Perhaps we might start on some vasopressors. Oftentimes, we're going to use norepinephrine or Levophed for our vasopressors here, and that helped for a little while, but she's really not looking good at this point. She's intubated. Her kidney function is starting to teeter a little bit. So at this point, maybe we say, well, we've continued to go up on pressors. We've given some volume. Not quite so sure about her heart function, so maybe we give some more vasopressors. And maybe some more volume after that when we're still struggling. So this is somebody who came in with a septic shock picture, came in with a very severe distributive shock picture, and really continued to deteriorate. And then we get to the end of volume and vasopressor administration, and we say, okay, well, what next? And at this point, we're on all the pressors. We've given her all the things, and her blood pressure, occasionally will look a little bit better. Systolic in the 90s, low 100s, but over the course of several hours, continues to fall with a MAP below 60. And my question to people who are caring for patients like this is, did we ever figure out exactly what the problem was? Because when we make an intervention, remember that dehydration picture, when I gave the person who is dehydrated, when we give them volume, they get better. So did we actually figure out what the problem is? Now we know that she's infected, but this has been over the course of 10 days, and we're still struggling with our hemodynamic status. And we've gotten cultures back. She's on the proper antibiotics. So what's going on with this person? So sometimes what can happen with these people is we go from a distributive shock type picture to a cardiogenic shock type picture because of the treatment. Now, all of this treatment is appropriate for somebody in distributive shock. There's nothing wrong with volume and vasopressors. The issue is when we fail to immediately recognize that they have switched from a distributive shock picture to a different type of shock picture, which is a very difficult clinical assessment to make. So I really encourage people to be investigating what's going on afterload-wise. What are the differences in this distributive shock picture versus this cardiogenic shock picture? And how do I pick up on those subtle changes in those patients when I don't have advanced monitoring? Now, if I do have advanced monitoring, so we talk about septic shock, we talk about distributive shock. This is very characterized by really severe, widespread vasodilation. So in these individuals, these folks are going to have really big blood vessels, and that's why, treatment with high vasopressors and early intervention of vasopressors can become very, very helpful. But when we look at something different, we look at the cardiogenic shock picture. Remember, if this is my dilated vessel, this is my normal vessel, and this is my constricted vessel. And let's say this person, same patient, she came in septic, and at some point along this curve, now we don't exactly know when, but at some point, she swapped over to cardiogenic shock, and we missed this. We didn't pick up on that because the signs for sepsis were so prominent. Okay, so as we switch over to cardiogenic shock, what happens is the heart is very, very weak. And so we take a weak heart, and this is true for any patient who is experiencing any type of heart failure, is what we absolutely don't want to do to these individuals, if we can avoid it, is to make the heart even weaker. So what we absolutely don't want to do, remember this very constricted blood vessel is going to be the highest workload on the heart. High workload on the heart. And how do I know that? How do I know somebody is in that scenario? Well, they've got a really high SVRI. They've got a really high afterload. And that's what that elevated SVRI tells me, is that this person has a very, very high afterload. So the treatment for somebody in really a severe heart failure who is vasoconstricted, let's say that their SVRI is, let's say, 3,700. Okay, now remember, their blood pressure, is 70/30. Now, why is their blood pressure so low here? The blood pressure is so low because this weak heart cannot pump out against this teeny tiny blood vessel. So it's got a very low cardiac output, a very low cardiac index, and a very high SVRI. A very low stroke volume, and probably a slightly elevated heart rate going on. So this combination with a low cardiac output, a low cardiac index, and a very elevated SVRI tells me something very important. Now, if I'm just looking at this blood pressure 70/30, how do I want to treat this person? Well, I want to treat them probably with some vasopressors, right? That sounds like a good idea for a blood pressure of 70/30. Well, actually, that is maybe the worst thing we can do for this person, because why is their blood pressure low? Because their cardiac output is low and the heart cannot pump out against this tiny little vessel. So if I start this person on vasopressors and I now have this tiny, tiny little vessel, even smaller, I've taken the 6 inches of the open doorway that I have been trying so hard to squeeze through, and now I've made it 2 inches. It's going to be even more work on an already very weak and injured heart. So what does that do? I start a vasopressor, and oftentimes, because we measure blood pressure peripherally, oftentimes what we see is an initial improvement in blood pressure, followed by a deep fall, because the whole time our cardiac output has been doing this. And that initial improvement is really just the constriction of the periphery around your peripheral arterial line, or in their blood pressure cuff that you're taking peripherally. So these are the patients that we start a vasopressor on. We see this improve just a little bit for maybe 15 minutes, and then we start to see them really fall again. And so how do we treat these people? Well, the indication, kind of the instinct, is to then go up on more vasopressors. Well, I started them on a vasopressor. I went up on the vasopressor. They got better for maybe 15 minutes, and now they're getting worse. So I want to make them better again. I want to go up on that vasopressor again. Once again, that is probably one of the worst things that we can do for these people. So how do we fix this? with somebody with really severe CHF who has an elevated SVRI, oftentimes what we're going to do for these people is actually give a vasodilator. I don't know how to spell that word. Now, if I'm looking at a blood pressure of 70/30 and someone comes up to me and they say, hey, I want you to give them a medicine that vasodilates, let's say 10 milligrams of IV hydralazine. If I don't know that my SVRI is 3,700 and I don't understand that the reason my blood pressure is low because the heart cannot pump anything out, I'm going to look at this person like they are absolutely crazy and think I am not doing that. However, what happens when we vasodilate this person who's very clamped down is we vasodilate them, we get them into more of a normal state. The heart that is exhausted and tired and just really wants to pump blood says, oh, thank you so much for making it less work on me. I can now actually do my job. And so what we end up seeing is an increase in stroke volume. The heart can pump more blood out per beat, which gives us an increase in cardiac output, which in turn gives us an increase in our blood pressure. So despite the fact it's just very nerve-wracking to give somebody with a blood pressure 70/30 a vasodilator. However, if you know why you're doing it and can sort of justify that way, it makes a lot more sense, and it kind of promotes kind of a calm feeling. This is sort of the same principle, or this is the same principle behind oral medication management in patients that have heart failure. I can remember when I first started in my career, I was seeing all these patients that had blood pressures of 90/60 and were on 3 antihypertensive medications, and I kept questioning over and over and over again, should we really give this? Like, this seems dangerous. Their blood pressure is already kind of low. And the feedback I got was, yes, give it. Yes, give it. Because I didn't understand this concept, and that made a lot more sense. So, I think kind of that understanding of what's going on with afterload, especially when we start to throw in issues with volume and issues with contractility, is really one of the things that I find so interesting about afterload and SVRI, and how it really contributes quite a bit and is very often overlooked. So off to the right, you'll see some causes of low systemic vascular resistance, and then some causes of high systemic vascular resistance. So I'm not going to spend a whole lot of time kind of reading through these, but essentially low SVRI is going to be anything that's really has dilated the vascular bed, a loss of vasomotor tone, of course, and then anything with high afterload is going to be anything that really makes it more difficult. So it could be, somebody who is grossly volume overloaded. It could be somebody who is really volume down, who's hypovolemic. However, the body's compensated by really really vasoconstricting, of course, vasopressor use, things like that. So how do we manage this? Of course, do quite the opposite. If we need to decrease the afterload, we're going to use some type of afterload reducing agent. This is just sort of a list of very common afterload reducing agents. I am actually I'll talk a little bit more about this in the vasodilator lecture, but I am actually not a huge fan of using nitroglycerin right off the bat, or for more advanced afterload reduction. And then, of course, if we need to increase afterload, we can administer, a variety of different types of vasopressors. So like I said, I'm not going to go into those. There are other talks that will be coming on those individual drug categories. Pulmonary vascular resistance, I mentioned this very briefly earlier. I wanted to include the equations, include the normal values, but I'm not going to spend a whole lot of time talking about it. The exact same principles that we talked about for systemic vascular resistance apply to pulmonary vascular resistance, just a little bit on a kind of a different scale. Of course, reasons pulmonary vascular resistance would increase, mostly going to be lung related. So contractility, we've talked about preload and volume. We've talked about afterload and afterload reduction. The last one is, of course, contractility. So when I'm assessing a patient for hemodynamic instability, there are a couple things that I'm going to do. So I'm going to look and say, is this volume, depending on actually which, what equipment and diagnostic tools I have available at my disposal, kind of tells me sort of where to start. As a nurse, if I've been trending central venous pressures, it will give me a little bit of an indication about preload. If I have a device that's going to tell me what my systemic vascular resistance is, I can measure afterload very easily. And really, the way we measure contractility is going to be by an echocardiogram, which is not something that I'm going to be performing and measuring super accurately at the bedside. But if the patient has a recent echocardiogram, that can be very, very helpful. So essentially, treating these patients tends to be a process of elimination. If I know that, they've had an echo, nothing has changed. I know, maybe this isn't a contractility problem, but now let me assess their volume status. I know this isn't a preload problem. That tells me, okay, I really need to focus on my afterload. And vice versa, if let's say I know that it's not an afterload problem, but it's really a contractility problem, that can kind of help me dictate which lever to pull. And oftentimes it may be a combination of these three. I may have a preload problem and an afterload problem, or I may have a preload, contractility, and afterload problem. But it really helps me dictate, if I treat the preload and now I can kind of say, okay, I treated that, things got better from that angle. I still have a contractility problem, still have an afterload problem. What are my next steps? And the really important thing about contractility is that this, when we talk about contractility, this is really the ability of the heart to contract independent of preload and afterload. So this is really about pump function, okay? And that's why we can't use stroke volume or cardiac output to directly measure contractility, because of course, if my preload is very, very low, my cardiac output is going to be low, because I can't pump things out of the left ventricle if nothing is coming into the right ventricle. So that's why we can't simply say, well, contractility is going to be your stroke volume, because it is kind of multifactorial. In the next talk that I'm going to do, we're going to talk a little bit about medications and the receptors that they work on. This is just sort of if you're dealing with medicines or you happen to have some additional information that talks about which receptors things hit. This is just kind of a brief overview as the common receptors relate to hemodynamic influence, vasoconstriction, contractility, dilation, things like that. And some of the drugs that list in there. So on this, once again, very brief overview: dopamine, dobutamine, epinephrine, norepinephrine, phenylephrine. And if you would like to learn more about kind of the vasoactive medications that are listed here, we can certainly do some of that, see one of my other talks, but I did want you guys to just have an idea of what sort of medicines there are available. So like I said, this has been kind of a brief introduction to hemodynamics. I hope that this has been helpful. If you guys have any questions about anything we've talked today, or questions about hemodynamics in general, please feel free to reach out, and I will answer them to the best of my ability. Thank you.